Well, good afternoon, everyone, and welcome to the July session of the Hypertension and Cardiovascular Disease Interdisciplinary Echo Series. My name is Benita Arokiraj, and I serve as the Echo Lead for the Constellation Regional Collaborative. Today, we will discuss and learn more about a community to clinic linkage program based out of the New York University. Let's take a quick look at the agenda to get us started. We'll begin with just some information regarding credits for your participation today, followed by introductions, and then the presentation by Dr. Joseph Ravenell from NYU. After the presentation, we'll open up the floor for questions and discussion. And we really encourage participation since the ECHO model was built on peer learning and sharing across disciplines. At the end, we will also go over details of our next session and talk more about the post-ECHO survey to help us continue to improve and tailor these sessions to your needs. Your attendance today and participation in our post-session survey counts for the following continuing education credits. So you will receive one AMA PRA Category 1 credit if you're a physician, one Certified in Public Health Recertification credit, one CHES or MCHES credit, and one Community Health Worker credit offered by the South Carolina Community Health Worker Association. So these are a lot of different credits with different processes. So I will send an email after the session with instructions on how to complete the post-ECHO survey and receive certificates or their respective credits for your participation. So with that, I believe Shannon already put in the chat, but I would love to see who's in the room with us today. So please take a moment to introduce yourself in the chat by providing your name, employer, credentials, and email to receive that email regarding the survey. So having that information will help us communicate with you too. And as the responses come through, I wanted to share a picture of my team, the Constellation Regional Collaborative. We are funded by a 5-year CDC cooperative agreement, the Innovative Cardiovascular Health Grant, to address cardiovascular health disparities in the Southeast US, namely Florida, Georgia, North, and South Carolinas. We have 4 program lines, one of which is this ECHO series. And together we support the planning, outreach, and execution of each ECHO session. The team is also incredibly grateful to receive counsel and support from the subject matter experts that you see pictured here, not just for ECHO, but for the broader work of the Constellation Regional Collaborative. And I believe I saw a few people join. So if you're on the call, do you mind coming off of mute and introducing yourselves?
Okay, can you hear me?
Yes.
Okay, my name is Yvette Jives. I'm from Asheville, North Carolina. My program is HERS LLC. I'm a nurse and a social worker and a certified CHW.
Thank you for joining us.
It's now good afternoon, everybody, at least here in Columbia, South Carolina. Don DePetty, thank you, Benita, for getting us all together again as usual. I'm at the University of South Carolina and the Floyd School of Medicine here in Columbia. I'm former dean of the School of Medicine, and presently I'm the Health Sciences Distinguished Professor at the university. I am honored to serve as a senior advisor for the regional cooperative and the CDC grant, obviously, that's supporting this series as well as the total efforts. And also, as a disclaimer, I'm a senior advisor and consultant to the Pan American Health Organization and the World Health Organization as they relate to the Hearts program, the Global Hearts program out of Geneva, and the Hearts in the Americas program out of Washington in our region. I'm really, really looking forward to this. There's been a lot of obviously very, very interesting information, positive outcomes, and I look forward to Joseph's presentation. But before that, and I'll conclude, Benita, I want to give a big shout out to Mike Young. Hi, Mike. I've not forgotten about you. I owe you an email. I get it.
Amazing
But I
people here
owe Mike
today.
an email only because we as a team had a tremendous visit at the Good Samaritan Free Clinic in here in Columbia. And Mike, thank you very much for welcoming us, and we will get connected. And please, in the interim, anything we can do for you and the staff, and get back to them, please, and tell them how much I enjoyed it. I've already heard from one of your students, student Yair. He would like to talk more about our laboratory and our basic science study. So anyway, Mike, thanks for joining
Amazing.
us and being part of the collaborative.
Thank you. You guys are all awesome.
Thanks. Thank you, Dr. DePetty. Dr. Bretler, I see you're on the call. Are you able to introduce yourself as well? Okay. Oh, I think you're muted.
Hi, everyone. Oh, can I go ahead and introduce myself?
Oh, sure.
Oh, okay. Oh, hi, good morning, everyone. My name is Jazwell Okagumoha. I am a recent graduate student from Wharton University, and my research primarily focuses on indigenous food and how they can help individuals manage certain health conditions such as cardiovascular disease, hypertension, and diabetes. So that's pretty much why I am interested in in this meeting to learn more about how, you know, the holistic approach, not just only food. Thank you.
Yeah, thank you for joining us and introducing yourself. I will move on to our didactic and case presenter of the day. We have Dr. Joseph Ravenell, who is a full professor of population health and medicine with tenure and associate dean for professional development at NYU Grossman School of Medicine. He is a primary care physician and health equity research scientist. Dr. Ravenell has led multiple federally funded trials to test community-based strategies to improve colon cancer screening and cardiovascular disease prevention among Black men throughout New York City and beyond. This work has engaged a community-based research network of over 200 community-based sites like churches, barbershops, mosques, and social service agencies reaching over 20,000 New Yorkers. Dr. Ravenell's community engaged work was the subject of an invited TED Talk, which has received over 1 million views, which Mike Young talked about at the beginning. Dr. Ravenell continually cultivates a holistic approach to promoting health equity through research, scholarship, and mentorship. And we're super excited to have you here today. I will stop sharing and we can get ready with your presentation.
Thank you so much, Benita, and thanks to everyone who has joined the call today. It's such a pleasure to be with you today and to share a little bit about our project called the Community to Clinic Linkage Implementation Study. So I'm going to just get my bearings here. And all right, can everyone see my slides okay? All right, wonderful. All right, so I'm going to be talking about the latest project that we just finished. And before I begin, I just want to give a huge shout out to all who contributed to this project, but primarily an organization called Community Health Action of Staten Island. It is an organization that does all of its incredible community work via community health workers who have just been amazing to work with. The community health workers that are part of CHASI did everything for this study from soup to nuts, including recruiting, including collecting baseline data, including delivering the intervention, doing all the follow-up, and really sort of proving that we have the power within our communities to do really anything, but also including this really important work and what I consider to be high science. All right, so I'm going to start by just showing this graphic that really gets me up in the morning, and it shows the excessive cardiovascular mortality from hypertension among Black men. It shows that Black men have the highest mortality from hypertension. And it really is because hypertension, the reason that hypertension is so deadly is because it's not easy to prevent or to control. It often, and if we focus on control for a minute, people with elevated blood pressure have to first become aware, and that often requires entering the health system in some way. Often going to a doctor or a nurse is the way that it typically happens. And then the doctor or whoever the provider is has to make the diagnosis. And then once the diagnosis is made, then recommendations for treatment have to be made. But we know that every prescription that is written is not filled. And so we really have to think about how do we close the loop between the recommendations that are made by providers and how to actually make sure that those recommendations are implemented in order to ultimately get to controlled blood pressure. And so, that the sort of cycle that I just demonstrated shows that the primary care setting is a real sort of important place. Almost everyone who has hypertension has to partner with a physician or primary care provider in order to help control hypertension. The challenge for us is that for many Black men, we don't engage with primary care for a whole host of reasons that I didn't talk about, but cost, access, and medical mistrust are really important barriers that have to be addressed. But also are reasons why we see, and this data comes from the Dallas Heart Study, which was a population-based study of over 6,000 adults. And in that study, we saw that specifically among people with hypertension, that Black men had lower engagement with primary care. And we asked why. Mistrust was definitely one of the things that we found, but also this notion that I don't need a doctor if there's not something acute going on or something that I can feel. And so we saw that as an opportunity for us to really center that notion in a health education in intervention. But we also had to think about where are we going to find the men if we're not going to find them in primary care settings. And so that gave birth to the idea of going to barbershops or other trusted community venues. Churches are other places that fit that bill, but barbershops we specifically focused on because of the special place that barbershops have in Black communities. Thinking about myself, I think about way back in the day when my father would take me with him every 2 weeks to the barbershop, and we would meet with the same barber, and the same cohort of men were there at 10 o'clock on a Saturday morning. And as a young boy, I probably was privy to some conversations that I maybe shouldn't have been, but I learned that it's a place where we talk about anything, and it's a place where Black men feel a sense of trust and confidence that what they talk about, what they say, is going to be kept in confidence, but also that they can really feel safe to talk about anything. And one of those really important things they talked about was their health. And they, trust me, they talked about it all. And so years later, when I was thinking about how can we reach Black men, all of that sort of came back to me. And I was fortunate to learn that there were other people who were also doing this work. And in fact, the work in barbershops focused on looking for hypertension really started back in the 1960s when the American Medical Association demedicalized measuring blood pressure to try to get ahead of the epidemic of hypertension that was really having a very negative impact on Black communities. Back in the 1960s, the stroke rate among Black men was 900 times higher than the stroke rate among white men because of uncontrolled hypertension. So, as a way to get out ahead of it and as a way to empower communities to really take their health into their own hands, some incredible champions, including Dr. Eli Saunders in Maryland, Dr. Keith Ferdinand, in New Orleans, among many others, really started to galvanize Black communities. And I have to give a big shout out to the American Black Nurses Association, because Black nurses really took it upon themselves to really spread measuring blood pressure and screening for hypertension out into communities, which included schools, barbershops, beauty salons, and many other places. And so our idea to go to barbershops and to partner with barbers to do this was really a reincarnation of an older idea. And here is pictured Jay, an incredible barber who has a shop in Harlem. And one of the customers that he has, we were able to meet in a barbershop. His blood pressure was high, and I was able to right away refer him to myself to see him in my clinic for hypertension. So we actually tested an idea many years ago in Dallas, Texas, of actually measuring blood pressure. I'm looking for a slide that I don't see, but we actually taught barbers how to measure blood pressure and how to counsel their customers to go to the doctor if their blood pressure was high. And what's been said to me on many occasions is, Doc, you're cool, but we generally don't trust doctors because of some of the things that we've seen and some of the things that we that people that we know have experienced. And I'll tell you, any day of the week, a Black man trusts his barber more than he trusts his doctor. So we took that to heart and said, again, here's an opportunity where we can hopefully partner with barbers, leverage the incredible trust that barbers have, and hopefully show Black men that there are primary care doctors that they can trust, and that we can work together to get their hypertension under control. So, in a randomized trial of over 24 barbershops, we showed that barbers measuring blood pressure over the course of a year could actually result in a marked increase in hypertension control. And so what this graph shows is individual barbershops and the hypertension control rate changing over the course of a year. And so what we showed was that in the barbershops where barbers were measuring blood pressure, the hypertension control went up by about 20%, which is an amazing finding. Compared to in the shops where there really was not much of anything going on other than measuring blood pressure, that the control rate increased by 11%. Now, that is actually a pretty decent increase, but what we found was that us being in the barbershop and measuring blood pressure actually constituted a pretty significant intervention, which is why we saw the increase that we did. But we saw a twofold increase in that control rate increase in the shops where barbers were measuring blood pressure and referring their customers for care. So we were able to prove that concept. A later study showed that if you introduce pharmacists and bring them into barbershops and actually get people started on medications even sooner, that can result in a 20 to 25 point drop in their systolic blood pressure. And that was published in the New England Journal of Medicine back in 2018. So we were able to actually take this work and actually think about how can we translate it to hypertension prevention. So I live in New York City, which, as you probably know, has 5 boroughs, and one of those boroughs is the borough of Staten Island. Staten Island is one of 5 New York City boroughs that is very socioeconomically diverse. It also, unfortunately, is very socioeconomically segregated. And so many of the Black residents in Staten Island live along what's called the North Shore, which is in blue here. Now, so the good thing about this is where almost all of the Black barbershops in Staten Island are located. It's also where we see the highest prevalence of hypertension. So Staten Island really constituted for us a perfect place for us to think about how we can translate some of the community to clinic linkage models that we tested in Dallas, Texas. And so, in partnership with Chazzy, the Community Health Action of Staten Island, and their community health workers, we started a program called Take the Pressure Off Staten Island, where we, over the course of a year, and it happened to be the COVID year, which is why you see the masks, we worked with a barbershop to screen over 1,200 individuals for hypertension and to connect the majority of them to some kind of care. And these are just some pictures from that year. We also enlisted the services of a mobile van that helped us to reach more of the community. And what we found was that about 80% of the 1,200 people that we measured had either elevated blood pressure or were hypertensive. So you're probably aware that the American Heart Association in 2017, along with the American College of Cardiology, basically redefined the thresholds for hypertension. And so normal is less than 120 over less than 180. Elevated blood pressure, which is this category here, and about 50% of the Staten Islanders that we measured fell into this elevated category. But it's 120 to 129 systolic over less than 80 diastolic. And then hypertension is anything equal to or greater than 120 or equal to or greater than 80. And so again, we found that about 80% had either elevated blood pressure or were hypertensive. Now, this is a really important category, this elevated category, because it's one that often primary care providers don't really recognize and alert their patients to the fact that if they don't do something, that they're very likely to actually progress to hypertension. And there are several studies that demonstrate that. So we really wanted to intervene in this high risk group, and we wanted to intervene in places where the men felt safe and with people that with whom they felt safe, including community health workers. And so we put together this community to clinic linkage implementation program in partnership with the community health workers, where in a really important part of the story that I left out about our work in Dallas is that the barbers were incredible at measuring blood pressure and at referring their customers. But we found that many of them saw it as a burden and sometimes an imposition to the reason that they were really there, which was to cut hair. And so what we learned was that once our study ended, many of the barbers did not want to continue measuring blood pressure. And so we thought this was a perfect opportunity to engage community health workers who we know there are literally hundreds of studies that demonstrate that community health workers can be trained to do very finite and specific tasks, and they can be trained to do them incredibly well, and that they can do those out in the community in non-clinical settings as well as people who are professionally and medically trained healthcare workers. And so measuring blood pressure is one of those really important skills that community health workers can do and do well. So we designed this study around community health workers being in barbershops, measuring blood pressure at every haircut visit, but also screening for social determinants of health. And what we wanted to really look at is if we both screen for hypertension and social determinants of health, and if we have our community health workers focus on clinical care and addressing social barriers, that we would have a better chance of, in this high-risk group of elevated blood pressure, preventing those people from progressing to hypertension. And we created this incredible network in Staten Island that included primary care providers, social service providers, so that when we identified people in the barbershop who needed either medical care or needed some social challenges addressed, that we had that network there to offer support. And when the community health workers also offered counseling on lifestyle changes and also helped to refer and navigate people to where they could have some of their social needs addressed. And then, of course, they would have that well-known follow-up that happens in barbershops because we go to barbershops every 2 weeks, literally, and we have data to support that. I go a little bit less now that I have less hair, but still, we go very, very often, and it's a great place for chronic care management. So, what do we do in the CLIP study? The aims were to assess barriers and facilitators for adopting this CLIP model to prevent hypertension in barbershops and to come up with a strategy for how we would do this long term. Then we wanted to test this strategy in a randomized trial of 22 barbershops where we would enroll 430 men with elevated blood pressure and look at the impact of this, what we call barbershop facilitation. And this is a strategy that we really adapted from practice facilitation, but it really takes place in a barbershop where we really try to identify what works and what doesn't work with regard to screening and referring for hypertension prevention. And we also wanted to look at the impact of our facilitation strategy over an 18-month period, which in this work is considered to be long term. We developed the strategy and we recruited 22 barbershops. 11 shops were in the intervention group. In the intervention group, they actually received the barbershop facilitation compared to the control group where they did not receive the facilitation intervention. So the barbershop facilitator role was also played by a community health worker who helped to optimize the measurement of blood pressure and the referral process within the barbershop. But basically, everybody in the study, they got their blood pressure measured, they got referral for to primary care. The community health workers delivered lifestyle counseling. They were referred for health coaching if they wanted, and so basically everyone got this in the study. The one difference between the intervention shops and the control shops is that the intervention shops had a barbershop facilitator, and we wanted to look at the change in systolic blood pressure at 12 months. So the barbershop facilitator, what they were there to really observe what was happening with regard to measuring blood pressure and referring for hypertension prevention. And so after observing the workflow, their job was to work with each barbershop in the intervention arm to set goals, to make sure that the barbershops were properly trained to help to develop strategies to optimize the measurement of blood pressure and the referral of their customers, and importantly, to try to integrate all this into their usual workflow. As you recall, the barbers in our Dallas study didn't feel like it was well integrated into their workflow, and so the community health worker, barbershop facilitator was there to make sure that that happened. So these are who we included in our study. We really focused on Black barbershops in the North Shore. We measured blood pressure and other factors at baseline 6, 12, and 18 months. The community health workers did all of this. And the clinical outcomes that we had were systolic blood pressure, diastolic blood pressure, incident stage 2 hypertension, and then other patient-reported outcomes, health-related quality of life, physical activity. We looked at Life's Essential 8, the American Heart Association framework for healthy lifestyles, and also linkage to care. So this is the baseline data from the 430 men that we enrolled from 22 barbershops. You can see that we were able to recruit a fairly young cohort, and the facilitation arm and the self-directed arm. This is the intervention arm and the control arm. You can see that the groups are relatively similar in terms of their education, their health insurance status, as well as their blood pressure at baseline. One important difference is we were able to actually recruit in our study overall about 40% of men who identify as both Hispanic or Latino and Black. And this was really incredible because when you look at the hypertension literature, that group is really underrepresented. So we were really thrilled that we were able to recruit this cohort in our study, and there were a slightly higher percentage of this group in the intervention group versus the control group. So this is what the flow through our study looked like, where the community health workers held monthly check-ins with the participants. They reviewed Life's Essential 8, the American Heart Association framework for healthy lifestyles. They assessed the need for clinical or social referrals, and then they also reminded the participants of the follow-ups of the follow-up visits coming up. And a huge shout out to the community health workers. They they crushed it. So as you can see, when we look at 6 month follow-up, they were able to re-engage nearly 70%. But if you look at the 12 month and 18 month, over 90% follow-up rate in the 12 month follow-up and over 96% in the 18 month follow-up. For people who do this work, this is unheard of in terms of follow-up, and we think it was due to the incredible trust and the incredible relationships that community health workers have with their community. So these are the results. The red is the intervention group, the blue is the control group, and the primary outcome again was systolic blood pressure at 12 months. And so what we saw was that in the intervention group, there really was not much change in the systolic blood pressure. In the control group, which we did not really expect, we actually saw a bit of a decrease in the systolic blood pressure. We saw a modest, a small increase in the diastolic blood pressure at 12 months. And we're still looking at how we can explain that. But if we look overall, there was not a statistically significant increase or change in either the systolic or the diastolic blood pressure over a 12-month period. And so this for us was actually a really important finding because you actually expect that over a 12 or 18-month period that the blood pressure would actually slightly increase. But we actually saw that the interactions with our community health workers, we think, resulted in a blunting of the increase that we might normally see. Secondarily, we looked at diastolic blood pressure at 12 months, and we saw that in the intervention group, there was a slight increase in compared to in the control group, but it was not statistically significant. We also looked at people who developed stage 2 hypertension at 12 months, and in the intervention group, only 7 men developed stage 2 hypertension compared to 13 men in the control group. And so there was slightly more progression to stage 2 hypertension in the control group. And when we look at stage 2 hypertension at 18 months, there was a very small number of people who progressed at 18 months, but again, it was not statistically significant. So the strengths of our study are that we really use a community engaged design, leveraging strong partnerships specifically with the barbershops and community health workers. We had very high retention in this study. This study focused on hypertension prevention as opposed to hypertension control, which we had done in prior studies. And we had a very inclusive and diverse group of Black men in this study. Some of the limitations are that we conducted this in just one urban setting, so it's hard to talk about generalizability. We also had a multi-component intervention, and so we need to do some more work to really isolate what are the secret ingredients. And then, of course, there are always confounders that some of them we can measure, some of them we can't. In conclusion, a community health worker-led barbershop-based community to clinic linkage implementation program can be implemented successfully using either barbershop facilitation or without barbershop facilitation and with what we call self-directed strategies by the community health workers. And then secondly, that systolic blood pressure changes were modest and similar between the arms, but the barbershop prevention program may help to slow progression to stage 2 hypertension and help address longstanding hypertension disparities among Black men. We're continuing to work on this model and see how we can not only tweak it but also scale it. And I'm really excited to hot off the presses report that we just got a grant to build on this model and actually teach community health workers to use new AI-powered cameras to screen for diabetic retinopathy in barbershops without dilating the eye. And so, in addition to screening for hypertension, we're going to look at if this model can work for screening for diabetic retinopathy as well. We are super excited to work with our community health workers and give them an additional skill set. This will be another randomized trial that we will be starting in the very near future. Just wanted to thank you for your time and attention. And I'm going to pause to see if there are any questions. Thank you very much.
If anyone has questions, feel free to come off mute or put them in the chat. I will monitor responses. But this is such an incredible study, Dr. Ravenell. It's, yeah, like just like looking at the different data metrics and to see what's worked or what you were able to address from the Dallas study, it was really informative. So thank you so much.
Yes, I have a question.
Yes.
Okay. Oh, thank you so much. That was a very interesting topic and presentation. And those findings were also quite revealing. But my question is that in your future strategies, is there a way that you guys are considering incorporating diets into prevention and management measures?
Excellent question, and thank you for that. So one thing that I didn't go into was what the counseling provided by the community health workers consisted of. And when we look at Life's Essential Eight, the very first behavior that they focus on is eating better. And so the community health workers absolutely gave counseling on healthy eating, but we also for those people who desired, we could actually refer them to a lifestyle medicine clinic, which we have here in New York City that actually operates out of our safety net healthcare system. And there's actually one of the flagship programs is actually on Staten Island. And so we did refer a number of the barbershop customers to the lifestyle medicine program. But I really appreciate your point. Diet is so important when it comes to both hypertension prevention and hypertension control. And it's something that we don't get the best education on in medical school. Many of us who are actually expert at it had to teach ourselves. I think we're probably better at teaching about nutrition and lifestyle medicine to our medical students now. But it's not something that we have always done well. And I'm really happy that the American Heart Association is really emphasizing the importance of a healthy lifestyle, which starts with healthy eating. So thank you for that question.
Yes, I will also add, why you're also considering adding diet into your prevention and management strategies. There are also, I don't know much about Black indigenous food in America, but there have been several documented studies about recipes or specific recipes that can actually help with hypertension from other indigenous food outside the Black community. I will also suggest that you should consider that as well.
Wonderful. Thank you so much for that recommendation. And the lifestyle medicine program does try to take in consideration cultural differences and really trying to sort of help people eat better within their cultural context, which we know is so important. So thank you so much for that.
Thank you for your presentation.
Mhm.
I have a question. I have a comment, and thank you so much for the work that you've done. And my comment is thank you, especially for taking the service to the people. So oftentimes, we do services, we have services, and they're available, but people can't utilize them because it is important. And I'm not
Mhm,
going to say that it's not on their radar to do,
mhm.
but several things. But if you can, anytime you can do a one-stop shopping, I think is great. And thank you for the shout out for the community health workers because I am a proud certified community health worker.
All right. Thank you so much for that comment, Christine. I completely agree with you. And the whole point of what we did was to really, take our work out of the four walls of the clinical setting and take it to where the people are. So I really appreciate that comment, Christine.
Yes.
We have a couple questions in the chat. So Alyssa asks, could you talk about the training you conducted with the community health workers and the barbers and any challenges you encountered in doing so?
Great question. So training was a really important part of what we did. One thing that we have learned in this work is that measuring blood pressure properly is something that often does not happen, particularly in doctors' offices. And so teaching the community health workers how to properly measure blood pressure and teaching barbers that as well. To be honest, actually was in some ways easier because the barbershop is perfectly situated for measuring blood pressure, right? So the American Heart Association, they recommend that patients in preparation for getting their blood pressure measured, that they rest for 5 minutes, that they be sitting in a comfortable chair with their feet supported, with their back supported, and their arms supported at heart level. Well, you've just described a barber chair to a T, right? And so in our design, we basically had the customer come, sit in the barber chair. The barber or community health worker would put a validated monitor, and it's always important to use a validated monitor. If you need to know where to go to find one, validatebp.org is where you can find any information you need about blood pressure monitors. But basically, the key is to put the cuff on, but don't start measuring right away. Right. So put the cuff on, allow the patient to get comfortable, and then after 5 or 10 minutes, you then press start on our oscillometric machine. And what that does is it basically builds the 5 minutes of rest into the blood pressure measuring protocol. And so we did detailed training on how to measure blood pressure, how to select the cuff, but then also, we gave the barbers and community health workers basically brief counseling skills. Also, a module on motivational interviewing. And so, while they didn't do sort of true motivational interviewing, we did go over the basics of it so that their counseling could be what we call motivational interviewing informed. And we didn't just do it once, but we basically came back to make sure that those skills were refreshed uh, uh, pretty much every single year. But I'm happy to provide more detail about the training. Feel free to reach out to me offline, and I'm glad to share any of the materials that we used with you.
And then Mike has a question. Have you seen or been involved with having community health workers and free clinics to treat and manage these conditions? If so, what has that relationship looked like?
So the community health workers that we were fortunate to work with in Staten Island are tremendous. And what is beautiful about CHASI, Community Health Action of Staten Island, is they are connected with one of the FQHCs in Staten Island, and so it really does sort of marry right clinical and social services expertise really in one spot. But because the community health workers are so community engaged. they really do spend most of their time doing outreach and making sure that any barriers that they uncover, they make sure that they are addressed in addition to connecting folks clinically. And so, you mentioned the relationships. That's really what it's about. That's why we were able to see 96% retention, at 18 months. It's because community health workers are hired not because of their degrees. They're hired because of their interpersonal expertise and their ability to form and maintain relationships. And it's something that I'm happy to say at NYU, we actually have a formal job title, formal role of community health worker that is not dependent on, having this degree or that degree. It really is, do they have the skills we need to connect to the population that we are serving? So thank you for that question, Mike. And I'm just so grateful to community health workers who we are privileged to work with.
Thank you. Absolutely. Community health workers, they fit everywhere and everybody benefits. So knowing that, I employ them. So they're so amazing. I'm a community health worker myself. So, but yeah, thank you.
Thank you, Mike.
There are a couple more questions, Dr. Ravenell, but I wanted to ask if you wanted to answer those now or do the case presentation and then come back.
So yes, I have a very brief case presentation, and it's really, just to get us get the conversation started. So let me reshare here and go to the last slide. Case presentation. There we go. All right, slide presentation. Okay, so our case presentation is Mr. B, a 35-year-old attorney who came in to get his haircut, and his barber, George, took his blood pressure and found his blood pressure to be 129 over 79. So George advised him to see a doctor, even though he felt just fine. So what should Mr. B do? And what can doctors or healthcare providers offer of Mr. B? So my first question is going to be, and you can just feel free to come off of mute, anyone who wants to answer. How do we classify this blood pressure? Is it normal? Is it elevated, or is it hypertension? And anyone can feel free to hop off. I mean, sorry, to hop off of mute and to answer the question.
I think it's elevated. I mean, systolic and diastolic. So the 79 looks normal, but 120 a little bit elevated.
Excellent. So you are spot on. Saida, is it?
Yes,
All right,
yes.
Saida, thank you so much. So you must have been at one of our blood pressure trainings because you are exactly right. So this is elevated blood pressure, and because it is in the range of 120 to 129 systolic over less than 80 diastolic. So really important. And so with elevated blood pressure, what should I do?
Can I
If
can I answer?
Sure, please do.
Oh yeah. Well, from what I know, I think with elevated blood pressure, this is not time to prescribe medications for the patient. I think it's a time to promote more of like lifestyle changes. Maybe increasing their physical activity intake, or also improving their diet.
That is absolutely spot on. Jaswell, is it? Jaswell?
Yes, please.
Jaswell, thank you
Just
so much.
I'm
Yes.
watching from Oakland, California.
Oh, awesome, awesome. Oaktown. All right. So you're absolutely right. At this point in time, it's not recommended by anyone that we start pharmacotherapy, but absolutely, this is when we want to really emphasize lifestyle changes. Lifestyle changes can be so powerful, but because they are difficult, many of us, don't really prescribe it, or recommend it to the degree that we should. And so the American Heart Association has some incredible resources. And I had a web page that was up that I don't see. But if you go to the American Heart Association a website, they have a ton of resources focused on Life's Essential Eight. But one other important thing that Mr. B should do is actually engage with his primary care provider. And that's so important because elevated blood pressure is underdiagnosed and underrecognized. And so, it's really important for Mr. B to go see his primary care provider. And it's important for that provider to actually give Mr. B a diagnosis, right? Diagnoses make us take things seriously, right? And so, the ICD-10 code RO3.0 is elevated blood pressure without hypertension. Please, 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 if you are in touch with any primary care providers, encourage them to add that ICD-10 to the problem list, add it to the chart, because what that does, it actually prompts us, right? If we have it as primary care providers on our problem list, right, it makes us take it seriously as well, and to emphasize those lifestyle changes to make sure that if our patients, right, still have elevated blood pressure when they come in, right, that we are talking about how they can change their diet, how they can increase physical activity, how they can get help with smoking cessation if that's something that is one of their challenges, how they can moderate alcohol. Right. And so these are all, how can they address their weight? These are things that are all so important that if someone has elevated blood pressure, can absolutely help them to prevent going on to hypertension, which we know opens the door to a whole host of other problems. So thank you, Jaswell, and thank you, Saida, for participating in that and for helping us to talk through Mr. B for our case. So I'm happy to take the remaining time to answer any other questions. And I can't see the chat, but let me see.
Yeah, I think
Would you mind,
Dr.
Benita? Thank
Petty
you.
had a question, I believe.
Yes.
Well, thanks, Joseph, very much. It's good to see you again. I
Hi,
guess
Dr. DePetti.
my I have a selfish question, and
Yes.
I'm going to speak from the CRC and our grant group. I'm assuming that most of these activities are grant funded, which is totally appropriate, as
Yes.
is ours. This right now is grant funded. So
Yes.
and we're halfway through our grant cycle, and already though we're starting to think about sustainability
Yes.
and of our own activities. How do we
Yes.
sustain this? The
Yes.
IECO series as well as the other pillars of our grant.
Yes.
Again, this is not a negative comment. This is a selfish comment. The
Totally.
barbershop studies have been longstanding. Kudos to you and Ron, by the way.
Yes, of
Obviously,
course. Of course. Shout
I'll
out to
always
Ron.
mention Dr. Victor.
Yes.
Really, really pioneered this, and then went to San Francisco, et
Hmm.
cetera.
Hmm.
Since they've been around, maybe not at these levels, the levels now with community healthcare workers, the levels with lower blood pressures, with
Hmm.
newer guidelines. So there's differences, surely. But thoughts about and I'm going to put we in this. How do we
Yeah.
all sustain this when the grants are done, et cetera? Yes, we could
Yeah.
always hope for renewals and we want renewals, but that's still a small population. How do we
Yeah.
extend this into the culture, our
Yeah.
medical and provider and health system culture? I
Yeah.
know Jeff Bretler, I thought was on here, or maybe he's not, but Jeff also has had experience similar barbershop
Yeah.
activity
Yeah.
with KP, Kaiser Permanente in
Yes.
LA,
Yes.
with some dramatic results, as
Yeah.
you do too. So
Absolutely.
I would have asked Jeff the same question. So help
Yeah.
me, help us.
Yeah, sure, sure, sure. And so again, thank you, Dr. DePetti, and yes, and definitely shout out to Dr. Ron Victor, who passed away 6 or 7 years ago. But he really is or really was a pioneer. He's the one who hired me, and so grateful to him because Without him, I would not be here today. So, um, but your question of sustainability really is the $1 million question, and it's one that we tried to address in our CLIP study by in the sort of the community network that we built, right? We really prioritized having payers at the table and having the New York City Department of Health and the Staten Island Office of the Borough President at the table. And so, as you fortuitously mentioned, right? Grants end, and when they end, it can be devastating to this
Yes.
kind of work because all of the effort that you put into building this, all of a sudden, goes by the wayside. But what I'll say, Dr. DePetty, is for the CLIP program, even though we just got this new grant that will enable us, that will give us 5 more years of funding to continue what we did and to build on it. The CLIP grant that we got from the American Heart Association ended in September, but we have still continued to do the work because we have had the right stakeholders at the table. So,
Wow.
thanks to some of the payers in Staten Island and the incredible community partners that we have, over 60 screening partners help to contribute to this work. We have continued to have monthly, at least, screening events in the community at barbershops, and also sort of broader community-wide events where we can continue to do hypertension screening, also bring people to the table to do screenings for several for several other things. And as we were sort of hoping and praying for more funding to come in. Now, we still have a lot more work to do as far as how do we sustain things at the level at which grants are able to support these
Yes.
programs. And that's going to take a little bit more work, actually a lot more work. But we're thinking about how can we tie what we do to reimbursement. We think that really is a sort of long-term strategy. And in places like New York and others where you can be reimbursed now for community health worker services,
Yes.
we're really thinking about how we can make sure that that we can leverage that model to be able to make that this one day will be a model that pays for itself. But and we actually, as I mentioned, have the ability to actually pay for community health worker services through FQHCs, but
Mhm.
actually trying to get some of those FQHCs on board. They already have so much on their plate, right? That trying to get this system up and going, just
Yeah.
the activation energy is significant. So we're trying to think
Yes.
about how can we support support the sort of building, of this kind of a program where, where it won't be too much of a burden to sort of wait for the reimbursement to kick in and to have the model, sort of pay dividends. But I would love to continue thinking about this with
Yes.
you, Doctor, and thank you for the incredible work that you're doing. And you can consider me a partner in this work.
Well, I always
Yeah,
have, Joseph. Maxine, remember he said that. Get Dr. Ravenell on record here. Mike,
yeah.
I
I think
heard
we
it.
need
We're
to
going to be following up.
All right.
be careful. Be careful
Oh
what
yeah,
you wish
Dr.
for.
Joe. Yeah,
Joseph, be
Dr.
careful
Joe.
what you wish for. You may get it.
All right. All right. Wonderful.
If Mike is still on, Mike, since we just, we were
Yeah.
just at your place and you're the, free clinics, not an FQHC, but it's very similar. Chime in, help us. Any thoughts from your perspective?
Well, I mean, I come from the community health worker workforce,
Good.
right? I helped develop the curriculums here in South Carolina and, the certification process. And I've even trained nationally through a consultation group called Everyday Life. So I'm huge in loving community health workers. And in my team, we recently got a Duke Endowment grant in collaboration with like a hospital system, another free clinic, and then United Way and another dental and vision organization. And our role was to boost the community health worker workforce, right? Because
Mhm.
that's kind of what we've been doing. We're a free clinic, and I'm on the board of the Free Clinic Association here in South Carolina. And my strength has been the voice of the community health worker, right? I'm a
Yeah.
champion,
Yeah.
and I just we've had one here at Good Samaritan Clinic for 4 years,
Mhm.
and I mean she is the glue. Like we are Two of our clinics don't even have signs. They're houses that have been
Ooh,
renovated into
wow,
clinics.
wow.
And the
Amazing.
people just know. For 25 years, people have known. And it's amazing. Like,
Yeah.
because these people, they're so passionate. Like you said, it's not about the credentials. It's about their heart, right? The people that get into this do it because they love it, right? And we're here to champion and make sure that they get paid appropriately. But I am here pushing for community health workers to be on free clinic staffs because it
Mhm.
will make the free clinics work so well because I see it. I've already benefited from it. Like my team has grown from she's now a full-time supervisor and she has another one underneath her. So my
Yeah.
work is to
Yeah.
grow that team.
Amazing. Amazing.
Um,
Well, Dr. Ravenell, it's 1 p.m. and I know you said you had another engagement, but thank you so much for joining and presenting on this incredible study. We've learned so much, and I will definitely share out the resources to everyone who joined the call and also send that email with the survey link.
All right.
Thank
Thank you
you.
all so much. It was my true honor to be with you today. So take care.